All right. First of all, thank you for the invitation to share this relatively underexplored topic. And thank you for all of your attendance. I'm Chang Yu-Chun. Today, I'll be discussing the interprofessional management of dysphagia, beginning from stroke patients. So my involvement in this research stem from my nearly 5 years of clinical experience in National Chang University Hospital in Taiwan, working as a nurse and assistant head nurse on a mixed unit. I primarily care for stroke and geriatric patients. During my time in the geriatric and rehabilitation unit, I observed a significant number of inpatients at risk of or actively experience dysphagia. As a frontliner at that time, I frequently encountered patients exhibit choking, coughing, or other clinical signs of aspirations during meals. Despite this, there was a lack of standardized screening tool available to objectively determine whether patients was at risk of dysphagia or to guide the appropriate nursing interventions. It was frustrating to feel limited in what I could offer these patients, especially given that eating is a daily need, right? Furthermore, nurse staffing are rarely provided or be training to ensure the patients can consume sufficient food efficiently and safely. This clinical gap is what drove me to enter this field of research. After involvement in this field, I realized that demand for comprehensive dysphagia care will only continue to grow in the future. Therefore, I will feel so pleased to share this with you today with the hope of building a proactive interprofessional team. So the outline for today is divided into three main parts. Since dysphagia may not be familiar to everyone, I will begin with a brief introduction to provide some essential mechanism and basic knowledge of swallowing. I promise I'll keep this section brief and concise. Following that, we'll go through the general and standardized management of dysphagia care, alongside an overview of current clinical landscape in Taiwan, Japan, and the United States. So in the first sessions, we'll go through and to understand what is dysphagia. Dysphagia is a clinical term used to describe any difficulty or discomfort associated with swallowing. In short, dysphagia occurs when a swallowing impairment disrupts the safely and effectively transporting a bolus into the stomach. The bolus is the thing, maybe the food, the liquids that is into your mouth oral cavity. That is called a bolus. Generally, we can look at this. From two clinical perspectives. The first issue shown on the right is concerning about the efficiency. This occurs when a patient physically struggles to transport the bolus effectively, either try to get it into the mouth, into the oral cavity, or propelling it from mouth down to the stomach. The second issue shown on the left concerns about the safety. A patient might be able to initiate swallowing to put the food into the oral cavity, but the bolus accidentally enter the wrong pathway. Because the esophagus and the airway are anatomically close and share a common upright tract, a misdirect bolus can enter the airway. Therefore, this is of course a severe compromise the patient's safety and lead to aspiration. So it is therefore easy to understand the adverse clinical outcomes associated with dysphagia. First, if the food cannot successfully reach the stomach to be digested, the nutritional intake is insufficient, which double the risk of malnutrition. And if the food enters the wrong pathway, it frequently causes aspiration pneumonia. Both of these primary complications create a ripple effect, leading to depressions, a reduced quality of life, prolonged hospital length of stay, even days. Furthermore, if we fail to identify or provide proper care for patients at risk of dysphagia, it results in substantial financial burden, money, increase the healthcare costs by approximately 12,000 United dollars, and which is equivalent to around 200 million Indonesia dollars. So in the standardized educations, I believe the in-depth training on swallowing mechanism is overlooked because I never learned from school. Nevertheless, a clear understanding of normal swallowing uh, physiology and mechanism, I believe, is essential. Because grasping this physiological mechanism provides the necessary clinical rationale for what screening tool we choose, the screening protocol, and what interventions we might apply in practice to tailor for the patient's individualized need. Traditionally, the swallowing process was divided into 4 stages. However, current clinical models now recognize an initial 5 steps. This is anticipatory stage. The first stage is the anticipatory stage, which occurs before the food even enters the mouth. So before the food enters your oral, before you put the food into your oral cavity. While historically overlooked, clinical research now have highlighted its importance. For example, this is particularly important for the patients with dementia or stroke patients with some cognitive deficiencies or inattention. These individuals patients may struggle to recognize the food and anticipate its volume and temperature. Consequently, they might refuse to eat, refuse the meal, or simply forget to eat. So as we established the knowledge before the definition of dysphagia, the inability to effectively initiate an oral intake, put the food into your mouth or into your stomach, is a kind of dysphagia. And later following the anticipatory stage, we move to the second phase, the oral preparatory stage. This phase is triggered at the moment the food into the mouth. So after you put the food or liquid, anything into your oral cavity. During this stage, the primary actions is mastications, which is chewing. The food is chewed and thoroughly mixed with your saliva to form a cohesive manageable bolus. As you can see in the right photos, here, bolus containment is crucial. The food must keep securely within the oral cavity to prevent both two things. The food will anteriorly leak out from the mouth or premature fall into your pharynx before the patient is ready to swallow. So clinically, we frequently see this mechanism fall in stroke patients, for instance, those with unilateral facial weakness, they have one side face cannot move, not be able to maintain their lip seal to maintain the food inside their oral cavity. So this will result in the food dropping out from their mouth. Furthermore, impaired tongue control after tongue cancer surgery can cause the bolus to fall back prematurely. This leads to an uncoordinated swallowing, which is frequently resulting in a choke or separation. The third phase is the oral stage, which marks the final faltering components of the swallowing mechanism. So before the stage 3, you can all control by yourself. During the stage, the tongue will elevate and articulate against your hot palate. This is trying to create a systematic anterior to posterior wave. To create a pressure, the pressures will effectively drive the bolus through your oropharyngeal into your larynx. So for some cases of stroke survivors, They diminish the lingual strength. Their tongue is not strong and and to push the food into their pharynx. So to understand this mechanical, I want to invite you to try a brief exercise right now with me. So first thing, please attempt to swallow your saliva. Like try to use saliva once. It's easy, right? But now you try to do this without elevates your tongue to touch your hot plate. So now you just let your tongue simply just relax and you now move your tongue now and try to swallow it, your saliva. So you will immediately find this without the pressure generates from your tongue to touch your palate. The act of swallowing became significantly more challenging. So this is an important of time in the oral stage. Then we enter the fourth phase, the pharyngeal stage. And here, what I call a danger zone. Once the bolus entered the pharynx, swallowing became completely involuntary, so you cannot control it once you stop your swallowing. At this point, there are three events will happen almost simultaneous to perfect at the same time to protect your airway. First, the soft palate will elevate to prevent your food liquids to go to the wrong place to your nose. Second, your larynx will move upright and to close your airway. So this is another way to protect the airway from the food exiting into. Third, the pharyngeal muscles will contract to push the bolus toward your upper esophageal sphincters here because they will push your food to your esophagus. So if this swallow reflex is delayed or weak, for example, after a stroke or just that you're getting old, the air will remain unprotected for a longer time because you will have a harder time, you will have a longer time try to elevate to close your airway. So it will make it easier to put the patients at risk of aspiration. Finally, we reach the fifth and final phase, the esophageal stage. Once the bolus enter the esophagus, there is really nothing we can control now. So the esophagus will take over this swallowing movement and try to use the consistent contractions to move the food bolus down into your stomach. So depending on the underlying cause of dysphagia, different swallowing mechanisms may be affected. So measurements require different discipline for different impaired swallowing mechanism. For example, some patients with stroke or dementia may forget to eat or have a reduced awareness of the meal times. In this case, nurses and family members are now the central role to play an important role by providing a reminder and mealtime support. But if the patients with had cancer and they have underwent a structural change after surgery, so they may be like their tongue is removed, part of removed, or their tongue, or they cannot just move their lip, they cannot just open their mouth. At this time, the dietitians can help to modify the food textures and food consistency to make the swallowing safer and easier. So what if a stroke patient with neurological impairment? So their swallowing muscle and reflex might be affected and because of the disease, because of the brain damage. In this case, the speech language therapist or SLP will try to assess the current swallowing functions and provide rehabilitation to help to restore or to recover a self-swallowing. So although today's presentation focuses on dysphagia in stroke patients, I would like also to highlight that stroke is not it's just only one of the many causes of dysphagia. There are many other conditions that can impair swallowing, and these also deserve our attention. So the stroke-related dysphagia is a good starting point because it is is common and well studied now around the world. But because the cause of dysphagia might be similar, and even though the etiology of the cause is different, because of the effect of because of the I'm sorry, say again, because the cause of dysphagia might be similar for a different to affect a different mechanism. The knowledge and clinical skill we develop here in the stroke patients can also be applied to the patients with other causes of dysphagia. So why not we just do that, right? And as you can see, there's around 30 to 50% of stroke patients experience dysphagia. It's quite high. Half of them will experience dysphagia. However, the prevalence can also be higher in some other conditions, such as dementia, Parkinson's disease, and head cancers, whereas the one problem may be more severe or persistent. And or maybe just because of the aging, it is still a problem that worth to care about it. So in the first sections, we know that dysphagia affects swallowing in two main ways. It can make swallowing insufficient. It can make swallowing inefficient or unsafe to say, right? And depending on the underlying cause, different treatment approach are needed. Therefore, different healthcare professions each have an important role in it. Although eating seems like a simple everyday activity, swallowing is actually a very highly complex process. So if we wanted to try to provide a comprehensive care for the patients with dysphagia, no matter it is caused by stroke, aging, or any disease, we still require close collaboration among multiple healthcare disciplines. This is why we will go to today's topic, the interprofessional management. So just in the second sections, we are talking about the dysphagia care. Just like many other diseases, dysphagia management follow a step-by-step process. Let's say we start from screening to screen out the patient at risk and refer them to a comprehensive assessments and diagnosis. And following that will be an appropriate intervention and follow-up. So when each member of the interdisciplinary or interprofessional team perform their role well, we can effectively reduce the dysphagia-related complications and improve the patient's quality of life. So to make the dysphagia care more easy to understand and logic, we'll use the 5W1H framework. What, how, why, who, when, where, to guide our next topic, our next section. So as we know and mentioned that dysphagia can lead to severe complications. Conversely, if it is identified earlier in management and to provide the appropriate interventions, the patients can experience a significant benefits and to improve the outcome. So when should we assess dysphagia? I think the answer is as earlier as possible. Currently, there is no single time point that apply to every disease, but the earlier we identify swallowing problems, the better the outcomes. So I recommend this flowchart because it classifies patients into 3 groups. As soon as the patient is admitted, or the first time you met them, we should consider their risk of dysphagia. Let's say we need to do the screening as early as possible, maybe at the first glimpse you see that. So now we define the patient into 3 different categories. The first is if there was no sign or risk of factors, like they're not stroke patients, they are not age patients, they're just an adult, a healthy adult, then you don't need to do anything. You just need to monitor it until there is a stroke or any dysphagia related risk appear. So this comes to a second category of the patients. If the patients have any conditions or clinical signs associated with dysphagia, they should receive at least a swallow screening as soon as possible to to determine whether the further assessment is needed. Now, let's say you need to try age the patients, okay, to see whether they are at risk or not. Finally, the third category is that if the patient is already or know they have a diagnosis of dysphagia, you don't need to do a screen again. You just need to process to refer them to like a rehabilitation physicians or SLP, ENT physicians to get a comprehensive swallowing assessment and to tailor the appropriate management and care plan for them. So once again, when should we do that? As early as possible and depending on whether they have the risk or not. So what and how we do after we identify the patients is at risk. So I believe that screening itself is an important intervention per se, because it helps to identify the patients who are at risk of dysphagia as early as possible. So once the dysphagia has been diagnosed, the intervention can be tailored immediately right after that, and to tailor to the underlying cause and the individualize the patient's needs. For example, stroke patients may benefit from a swallowing exercise to improve their swallowing functions. Older adults or patients with dementia who have difficulty on chewing or swallowing may require that dietitian's help or dentist help to then have their denture to do some food modifications. In addition, and the third one is a new approach that says neuromodulations. They are being effective to promote the recovery of their brain functions. So don't think that swallowing exercise is something that is needed after the patient is defined as a risk of dysphagia patient. Sometimes you can, in fact, they can be learned and just practiced by anyone before you even get a dysphagia, including ourselves, and you can learn for your parents. And therefore, there is a growing evidence that swallowing variety, because while we need to learn that for not only for the patients, but it is also benefit for you and your parents, because there are some evidence show that the swallowing variety that is dysphagia is closely associated with general variety in sarcopenia. So if you try to maintain your swallowing functions, you just to do some swallowing exercise, there may be help to preserve your overall health and independence as we age, as we get old. So this is like a very vivid. So now I can offer you some example of some fun, some easy to follow swallowing exercise video on YouTube. So it is very simple to start and practice at home. So there, like this one, the left one is filmed by our hospital, and the right one is demonstrated by speech language therapists. Don't think that it's very difficult. You just need to type the keyword like swallowing training on YouTube. You will receive some. And like when you say when you do like to blow your cheek like this one, and try to move to try to push it. You just to resist it like this one. You will get your muscle or your chin muscle more stronger. And maybe you can also have some exercise to do to training your tongue muscle or your swallowing muscle. Then you can just like put your tongue between your teeth, like the right photo here, and try to swallow. So you'll find it's really difficult to do that. But once you keep doing practice exercise, it can make your swallowing functions much more stronger. So just try to do that, and you can share this with your parents, your family. But if you still think this is too difficult to do that. There's there is a one thing is a very good swallowing exercise. Is singing. So when you sing, you will just like keep move your mouth and try to do some articulations, to do some pronunciations, and to do some like breathe as well. And there is a pattern. You will keep training that one. This is a so one. So singing is a very good exercise to improve or to preserve your swallowing function. Singing. And another important topic, especially for nursing care founders' perspective, is the oral hygiene. This is often ignored, particularly in the patients with nasal gastric or NG tube. Many people assume that it's because these patients with NG tube they are no longer eating by their mouth, so the oral care is no longer necessary, right? This is wrong. This is wrong because the good oral hygiene is essential for preventing aspiration pneumonia. So think about this one. Even though the patients with the NG tube are not swallowing food, they are still produce the saliva, right? And they must swallow it. But because they swallowing late, because they do not eat from their mouths, their swallowing functions will gradually degenerate or impaired. So the saliva can pour in the mouth and then may be accidentally just like to swallowing and choke. So imagine, let's say if the mouth is dry and the oral hygiene is poor, the saliva will contain a much more higher bacterial load, right? There are larger bacteria in their saliva. So once they accidentally swallow the saliva, the dirty saliva into the airway, they are choked. They will be very easier to lead to the aspiration pneumonia because you put something dirty into your lung, your airway, your aspiration systems, right? And research has also shown that if the patients with NG tube, if you do oral care for them, so even though they choke, the saliva is clean. So there is not much bacterial load in that one. So you just like you accidentally choke something clean, that might be not that easier to lead into aspiration pneumonia. That way, maintaining a good oral hygiene is one of the simplest and most effective strategies to reduce the aspiration risks from dysphagia, and this is exactly what we nurses can do. Also, I also want to highlight, you can see here the tongue. Sometimes we do oral care, we only do brush your teeth. But don't forget your tongue. Sometimes your tongue is really like dirty, molded. So if you do not clean your tongue, there will still be a lot of bacteria over there. So your mouth is still dirty, your saliva is also dirty. It will also easy to get aspiration pneumonia. So the last thing is when addressing the clinical management of dysphagia, we must recognize when we say about who should do lights, this is one. We must recognize this no single profession, no single discipline can encompass the entire continuum, the entire spectrum of dysphagia care. Because unlike the many other medical conditions where physicians and we nurses are primarily responsible during the acute phase, and other professionals such as physical therapists, dietitians, speech language therapists will become involved later during the rehabilitation. However, this dysphagia management requires interprofessional collaborations from very beginning. For example, during the initial screening phase, nurse caregivers are often in the best positions to identify patients at risk of dysphagia because they spend the most of time with them. However, the speech language therapists and physicians can also perform a swab screening. There is no regulations that who can do the screening. It seems that all the healthcare professional can do this one. But when it comes to the comprehensive assessments and diagnosis, the complex nature of dysphagia means there's a nurse, physicians, and speech language therapists. They all contribute from different perspectives, but complementary uh, to do the comprehensive assessments. So working together allows this team to gain a more complete understanding of the patient's swallowing functions and develop the most appropriate measurements plan. And as you can see, there's a boundary between the professionals' roles become much more distinct. Now there is a blurred boundary between the disciplines when we talking about the dysphagia care. So rather than working in isolations, the different disciplines overlap and collaborate to provide the best care for the patient. Then there's consequences. What does the best interprofessional teamwork look like? Which is also our topic for today. So some would say although dysphagia management is multidisciplinary interprofessional teamwork, I still believe that nurses can play a central role throughout the entire care pathway. Because as the largest healthcare professionals and team members who spend the most time with patients, we nurses are well positioned to provide a timely care, identify swallow problem earlier, and try to coordinate appropriate referral. So everything just begin from the very beginning, and this is what nurses can do. But honestly, I still have no answer for the best teamwork look like. Although I believe the nurse is a good choice, is a good position to provide the very first dysphagia care. I'm not saying that winners should take their own responsibility on this dysphagia care. And the key questions will be: how can we develop effectively interdisciplinary, interprofessional collaborations without creating additional workload for nurses, but still can improve patients' care quality. So although I don't have the answer, I have some opportunity to experience the dysphagia management in the different healthcare systems, including Taiwan, Japan, and the United States. So through this experience, I have observed a different approach to the multidisciplinary interprofessional collaborations and how each systems integrate dysphagia care into clinical practice. So today, the last sections, I would like to share what I have learned from this setting, this country, and hopefully encourage everyone here to consider the best strategy or the best teamwork that might be work within your own healthcare environment in Indonesia. So in Taiwan, we are still in the process of developing national guidance for dysphagia management to address the diverse cause of dysphagia. So although I'm now presenting on behalf of Taiwan, I still think that with Taiwan is still gradually establish our guideline, our national guideline to do the dysphagia care across all the disease categories. So in Taiwan, there's the interprofessional collaboration is increased and recognized as an essential part of dysphagia care now. So now you can see we are now building some chewing and swallowing center for dysphagia care, and there are lots of different healthcare professionals into this team. But however, according to my observations, this team are typically led by rehabilitation physicians, dentists, and speech language therapists. In recent years, I just observed that there are still some nurses, there are very rare nurses to get into the associations. Even me joined these associations just like 4 years ago. But during these 4 years, there's still lack of nurses to get involved into these associations. They are mostly controlled by the physicians, dentists, or as a speech language therapist. Another thing is that even though winners do not contribute to the associates too much, but we still try to build some specific, some specialized dysphagia clinic. And with just as I mentioned before, it's a multidisciplinary team try to expand across a comprehensive care for patients with swollen disorders. So I'm going to just focus on stroke patients. However, the nurse still not yet take a central role in this team and are still underrepresented in the professional dysphagia organizations. I think this is despite the fact that the nurses are far outnumbered, well, a lot of outnumbered than the speech language therapists and spend most of time with the patients. In clinical practice, nurses are often expected to perform the dysphagia screening only and just to monitor whether the patients doing the suggestions from physicians or speech language therapists. Also, there is no current national standard screening tool, training program, or competence framework specific designed for nurses. So represents an important gap and valuable opportunity for future development, for the nurse. So without the involvement of nurse here, I noticed there is some problem here. This data is part of my doctoral dissertations, and this clearly reflects that in the finding that we try to do a dysphagia screen in several hospital units within high prevalence of dysphagia, which is the ENT neurological units, rehab units, and geriatric units, to see the preference of dysphagia risk for these patients and about their treatments or anything related to dysphagia care. So as you can see here in the lower column here, lower row here, you will see that approximately 40 to 43% of the patients will identify as being at risk of dysphagia. It's quite high, right? However, there is only small portions of these patients who subsequently referred to speech language therapists for further assessments. One encouraging finding is that dysphagia care is relatively well established in the stroke rehabilitation units. In the rehabilitation units, you can see around 71% of patients received a speech language consultation to see whether they need the dysphagia care or not. But in contrast, referral rates were much more lower in other high-risk settings, other higher units. Like in the geriatric units, fewer than 10% of at-risk patients were referred. And the most concerning thing is that in the ENT ward, where a patient has undergone some surgery or radiotherapy from head and neck cancer, and these conditions were placed at risk of dysphagia, a very high risk of dysphagia. However, in this setting, no any patients had been referred for a speech language therapist or a speech language assessment. I think these findings suggest that the dysphagia care remains highly dependent on the patient's diagnosis and the clinical specialist, rather than on their actual swollen risk. So this is also highlight an important opportunity to improve the early identifications and referral through a more systematic interdisciplinary approach, and maybe what nurse can do or how nurse can involve in this dysphagia management in Taiwan. And another important lessons come from Japan, which I would consider one of the world's leading countries in dysphagia management. Many of assessmental rehabilitation techniques and models of dysphagia care that were used today were originally developed or pioneered by Japanese researchers and clinicians. Japan has made a remarkable contribution to dysphagia research, education, and clinical practice, particularly because of their rapid aging populations. So when I visit Japan, I have the opportunity to observe their dysphagia management firsthand. What impressed me most was the dysphagia care is not the responsibility of a single professional. It is truly embedded into the healthcare systems by a multiple interprofessional management collaborations with within among the physician, nurse, behavioral therapist, dentist, dietitian, and other health professionals. Another key strength is that each professional has a clear defined role and responsibility, supported by well-established SOP for these facial measurements. And because everyone understands their role and follows a standard pathway, hospitals are able to provide this facial care for all inpatients, as recommended in our early major clinical guidelines. So this systematic approach helps to ensure the patients at risk are identified earlier and referred promptly to further assessments and management. Another role I would like to highlight in Japan's system is their specialized nursing role in dysphagia care. So there is a role called Certificate Nurse in Dysphagia Nursing, CNDN, and you can earn this certification after complete advanced education and specialist training in dysphagia management. Listeners are involved across the entire spectrum of dysphagia care, from screening and comprehensive assessment to treatment, follow-up, and patient education, even some consultations for nurse and patients. They also play an important role in education other healthcare professionals, developing some clinical protocol, and promoting best practice within their institutions. So the CNDN rule goes beyond what is typically expected for general registrars. Through advanced training, they acquire specialist knowledge and skill in dysphagia assessments, intervention, and follow-up. So their competence sometimes overlap with a speech language therapist practice, but the goal is not to replace the speech language therapist. It is to try to expand the capacity of the dysphagia care team and provide a more comprehensive patient-centered care. However, the CNDN can play a leadership and coordinatory role within dysphagia care team by combining the special dysphagia acknowledgements within their close and continual contact with patients. And they can also facilitate communications between the different professionals, coordinate care pathway, and help to ensure time and comprehensive dysphagia management. The last thing is I want to mention about the United States. So the United States is also considered one of the leading countries in dysphagia care, with their strong development across many aspects of clinical practice, research, education, and professional training. As you know, United States, the Western country, is always the leading countries in any medical field. So one key point I would like to highlight here from the United States model is that the role and the responsibility of each profession are clearly defined. So they do not have a very vivid boundary, rather than overlapping extensively. Each discipline focuses on its own area of expertise and contributes an appropriate stage of care. So in this model, nurses have a strong focus on the dysphagia screening. So they just do the screening. However, different from Taiwan, they can play a very important role in an early identification of patients, initiate their dysphagia care, and facilitates the referral to further assessments because they have a strong knowledge about dysphagia. So compared with the Japanese model, where specialists nurses such as CNDN, they may cover a broader spectrum of dysphagia care from screening, intervention, and education. The US model places stronger emphasis on clear defined professional boundaries. But compared to Taiwan, nurses in the United States generally have a greater autonomy and confidence in performing dysphagia screening, supported by the established protocol, training systems, and clinical pathway. Therefore, I would not to say the Japanese or US model is the best. So I think each system has its own strengths and reflects the characteristic of its healthcare environment, like workforce structure and clinical need. Like we know that the United States, the nurse is with a higher power, right? But in a Japan, the nurse sometimes we just cover lots of things, just like Taiwan, but they are try to very focus on one aspect to do a very in-depth training for some specific aspects like dysphagia. So I think the key is not to copy any one model directly, but to try to identify the elements that are more suitable and adaptable to our own healthcare systems. Finally, I would also like to encourage those who are interested in dysphagia research and clinical practice to become involved in a professional organization in this field. And I believe that effective interdisciplinary or interprofessional collaborations can only happen when each profession understands their role, their own competency, responsibility, and the unique contributions of other disciplines. So with this knowledge, we can better integrate the different expertise and work together to provide a comprehensive interprofessional dysphagia care. Therefore, I recommend some organizations such as DRS, Japanese Society Dysphagia Rehabilitation, JSDR, and the Asian Dysphagia Society. This organization brings together leading clinicians and research from around the world and provide opportunity to assess the latest evidence, clinical guideline, educations, and the professional network. So in this organization, you can also meet lots of different professionals, from different healthcare disciplines and their perspective. This is essential to build a stronger and more collaborative future for dysphagia care. So to conclude today's presentation, I hope I have shown that there are still many unmet needs and research gaps in dysphagia care, but there's still no universal accepted standard model for interprofessional dysphagia management, and the role and competence of nurses continue to evolve. And we still lack some SOP, some training in Taiwan, maybe in Indonesia as well. So this also means there are tremendous opportunity for research, innovation, and collaborations in the dysphagia field. And that is the last thing is that I believe that by working together, there's to echo the title, the topic of today, this interprofessional measurements for the specific disease. Working together across disciplines, we can continue to improve the dysphagia care and ultimately enhance patient safety, nutrition, and quality of life. So this is all I have today. Thank you so much for your attention.